A cesarean birth is a delivery that occurs through the abdominal wall by an incision that the physician makes in order to take the baby out. It's indicated for a woman who's had a history of a previous C-section birth or other uterine incisions. Any sort of labor dystocia or a failure to progress in labor, non-reassuring fetal heart tones, so those are your variables and your late decels, or fetal malpresentation such as breech or a different or a footling type of presentation. Having a C-section is a major surgery. It is a major abdominal surgery and it has risks to mom and baby. It does increase the maternal risk of death, mainly from hemorrhaging and systemic infection. For the fetus, they have risk of severe respiratory distress and inadvertently delivering a premature fetus who's not able to breathe on their own. Maternal complications include an accidental laceration of the uterine artery or other vessels, nicking the bladder with the scalpel, accidentally cutting into the ureter or bowels. Hemorrhage that requires a blood transfusion. So a hemorrhage for a C-section is greater than 1,000 cc's of blood loss. It may require hysterectomy if they cannot get the bleeding under control. About 15% of women develop a wound infection from their C-section wound. Pneumonia is always a risk for any surgery. Postpartum hemorrhage and thrombophlebitis or other surgical related complications. So this is a major surgery, so there will be considered like a surgery patient, and that's how you will treat the woman. So she's a postpartum patient and a surgery patient. So she'll have both of those things that need caring for. A VBAC stands for a vaginal birth after a cesarean section. It is about 60% success rate. The woman cannot have no more than one previous C-section. She also cannot have had a classical vertical incision line. She can have a low transverse abdominal incision and a low transverse uterine incision to be a candidate, but she cannot have the low transverse abdominal incision and still have a vertical uterine incision. So if she's ever had the vertical uterine incision, she cannot do the VBAC because her risk of a uterine rupture increases dramatically. Now, UE must have an OR and adequate staff on standby in case of a uterine rupture. Now let's look at what a uterine rupture looks like, because this is what the nurse has to watch out for a woman who's going to VBAC. So mom may report a popping sensation and she'll have excessive pain than she has had before. She'll also have a fetal heart tones that exhibit fetal bradycardia or deep variable decels. So we have this uterus that has popped, and now we're having these symptoms. So we're also going to have unrelenting or uterine contractions that are followed by a disorganized uterine pattern. So they're going to feel like it doesn't stop, and then it's going to be disorganized. The mom may also have increased fetal station felt upon vaginal exam, so the baby kind of rises back up into the uterus, vaginal bleeding or a bloody show. And then if the baby has come through that uterine rupture, you could feel the baby through the abdominal wall. At this point, mom is going to start to develop peritonitis pretty quickly because now the uterus is open to the peritoneal cavity, and we're also going to start having these signs of shock because of that shift in fluid and what's happening in her body. So she's going to have signs of maternal shock. So her blood pressure is going to drop and her heart rate is going to rise. I also want to point out that LPNs are not allowed to take care of women who are VBACs.